Welcome back for part 3 of the lecture series on chapter 3, a very long chapter, isn't it? It's getting a lot of stuff in there. We're going to be covering today the slides number 30 to 48, and then there are some quiz slides, and we'll go over there. I think 5 of them. We'll go over those as well, and just review the types of questions that would cover the material. I think that those 5 questions can be drawn from, or are drawn from, any place in the chapter, not just this third segment. We're going to share a screen, and let me bring up and enlarge slide number 30. And I'm just going to go back one to orient you. We just completed the vertebral arteries and we got them into the cranium. And in the several slides before that, we followed the carotid arteries and got those into the cranium. But we haven't done anything with them yet, and that's where we're going in the next few minutes. So far as the blood to the brain is concerned, you have seen the pathway of blood returning to the heart, leaving the heart to go to the lungs to get oxygenated, coming back to the heart, and then leaving through the ascending and arch of the aorta and the descending aorta to the entire body, including up to the head with those 4 branches, 4 main pathways, and the only pathways really. The 2 carotid arteries, starting with the common carotid and then going to the internal carotid, which actually enters the cranium, and the 2 vertebral arteries. So we've already covered that with this slide and the previous several. And so now we're going to follow the pathway of blood and the arteries carrying them within the cranium itself. And this particular illustration is from the book. It shows the connection of the carotid and the vertebral arteries to each other through the circle of Willis. I think you might have studied it before in anatomy and physiology, though I'm not certain, and we're going to look in a little more detail right now. But let's start with the internal carotid artery, and it is labeled here, but let me point it out, starting right here. Now, what that would be is the cut stump of an artery cut at the point of entrance into the cranium. So you saw it ascending up the neck, goes through the bone and into the cranium. There it's cut. So we see one on one side, and we see one on the other. And so that would be an internal carotid. And almost as immediately, as soon as it enters the cranium, it divides into a middle cerebral artery and an anterior cerebral artery. And these are arteries that are going to supply huge areas of the cerebrum. So we're going to look at a little bit of detail in several slides at those. But let me first show the division. Here it is, middle cerebral, and you can barely see it on this side, on your left. That's actually a right side of the brain. You can barely see it here because it's kind of hidden by the anterior pole of the temporal lobe. Here is temporal lobe. Here's the front part of it, but I'm not going to call it the front part. I'm going to call it the anterior pole. And it's obscuring that lobe. Now, if you pull it back, you can see it in there going through the area between the frontal and the anterior pole of the temporal lobe. What they've done over here on this side, on your right, is they've actually cut that off. And here you can see the middle cerebral artery coursing through that. That's actually the Sylvian fissure. So it's coursing out through the Sylvian fissure and then dividing it into a bunch of branches covering the whole side of the brain. And we'll look at that in detail because that's very important for speech language and minor hemisphere syndrome too. That artery, the middle cerebral artery, and we'll end up abbreviating it, the MCA, a lot. Major artery in terms of speech, language, and cognition. All right, so division of the internal carotid into the middle cerebral and the anterior cerebral. Let's look at the anterior cerebral here. Here it is. Now we see it on one side, we see it on the other, but it disappears into the mid-sagittal fissure, the big fissure between the 2 halves of the cerebrum, the 2 cerebral hemispheres. And so we will look at later at that. What we're going to have to do to see that artery, the anterior cerebral, is cut the brain in half, right down the middle, and separate them. And then you can see the territory of the anterior cerebral. And that's quite large too, not as big as the MCA in terms of the territory of the cerebrum that it supplies with blood, but it's very big. All right, so now we're going to go to the basilar artery. Now, I haven't mentioned the basilar artery before, so let's start here. Let's start with the vertebral, and here we can see a cut brainstem. Actually, at that point, you separate brainstem above and inside the cranium from spinal cord below and inside the bony spinal canal. And we'll look over the course of a number of lectures at that area and how it looks inside and how it's constructed. But for now, we're only really interested in these two vertebral arteries that entered the cranium along with the spinal cord. Remember, I said through the foramen magnum, you have the spinal cord and two vertebral arteries, and there they are. And what they do is they follow along the ventral surface of the medulla. This is the medulla. You don't probably know enough landmarks yet to recognize it as such necessarily, but that is the medulla right up to here. And then here is the pons. Well, at the junction of the medulla and the pons, the two vertebral arteries come together and form a single artery known as the basilar artery. Here it is, the basilar artery. It's a single artery, and it courses along the ventral surface of the pons until it gets to the junction between the pons and the midbrain. And at that point, it divides into two posterior cerebral arteries. And it wraps around the brainstem and it goes to the posterior cerebrum. So we'll look at the posterior cerebral artery too, but we have to take a different view because you can see it wraps around. We simply can't see anything from this ventral view. It's obscured by the cerebellum out here. Here we've got cerebellum, and it's covering everything up. But we'll be able to expose it in a different way. All right, now, to complete what we need from this particular ventral view of the brainstem, we're going to complete the connections between those two pairs of arteries. And that is known as the circle of Willis. And it has actually three arteries that connect it up and make up the circle of Willis. Let's start at the front. The anterior communicating artery connects the two anterior cerebral arteries. And I'm going to point it out. I believe I'm going to try to point it out. Oh, here it is. Now this is kind of blown up. This is this part blown up, and here we can see it's a little tiny artery, and it just provides a linkage between the two anterior cerebral arteries, relatively close to where they divided off. Remember, MCA and ACA divide from the internal carotid artery and form those two arteries, and relatively close to that point, you have this linkage created by the anterior communicating artery. And I'll explain the purpose of the linkage in a moment. Now, the rest of the circle of Willis is completed by these two arteries known as the posterior communicating arteries, which link the posterior cerebral artery, here's the label, with the internal carotid, right at the point of the junction. So here we have an internal carotid divides into an anterior cerebral artery and a middle cerebral artery, and right at that point you have this linkage through the posterior communicating artery with the back part of the system. What do I mean by the back part of the system? The vertebral basilar system, it's called, which divides into the two posterior cerebral arteries. And then you get these three arteries connecting, anterior communicating artery and two posterior communicating arteries to make a circle. That's the circle of Willis. Now, what's the purpose of the circle of Willis? The purpose of the circle of Willis is to provide for protection against the possibility that there could be a blockage or an injury in one of those main sources, particularly the carotid arteries, one of those main sources of blood to the brain. if you have a good functioning circle of Willis, which younger people tend to have, you can actually have a complete cutoff of flow in one of the internal carotid arteries and still have blood supplied to the brain. You still got 3 arteries, and the circle of Willis would link it up. So let us suppose that this internal carotid artery right here, and that's on your right, but the individual who owns this brain, it's on their left, so it's on the left side, left internal carotid artery blockage. And this is very, very common in older people, especially. They get a block from atherosclerotic process that just blocks it off, starting with some blockage and progressing sometimes to full blockage. And yet we see people who have a full blockage and they haven't had a stroke. Now, how's that happen? Well, so what has happened is that though there's no blood coming in through here from the neck, the blood is coming from this side, and because this does have a blood supply on your left, the person's right, and it comes over here, and because there's no pressure over here being generated by a blood supply, it crosses the ACA, the anterior communicating artery, let me just call it that, and it goes through this little segment and then out through the MCA. So it goes here, across the anterior communicating artery and out through this anterior cerebral on your right, their left, and sort of backwards, because typically blood would be flowing in this direction through that initial segment of the anterior cerebral artery, but it goes backwards and then out through the MCA, and there's your blood supply. You can also get some coming from the posterior communicating, because there would be pressure, no pressure generated here, but pressure generated here, and so there's the blood supply. So we have examples, quite a few of them actually, of people who have are later discovered to have had a massive block of a carotid artery on one side and yet never have had a stroke. How did it happen? Because their circle of Willis was good enough to make up the difference. So that's the purpose of the circle of Willis. In reality, people who have atherosclerotic disease, from cholesterol and high blood pressure and all the things, we'll look at that a little later. They'll tend to have a circle of Willis that doesn't work as well either, because they've got atherosclerotic disease all over, but at certain points more than others. The division of the common carotid into the internal and the external carotid is an especially vulnerable location for the atherosclerotic disease process. So we do find blockages there more pronounced than other places. Nevertheless, their circle of Willis may not work well enough to make up the difference, and they do have the stroke. So I only want to show one more detail about the vertebral basilar system in the next slide, and then we're going to just focus on the 3 main arteries that supply blood to the cerebral hemispheres. All right, and here is very complex, obviously. It doesn't come from the text because I don't have a figure number, but this shows what you just saw with more details. And the point of the detail, well, let me just review. So here we have the 2 vertebral arteries coming together at the pons, and we're looking at a ventral surface, ventral view, coursing across the pons and then dividing into 2 posterior cerebral arteries. And if you study that real closely, you can find the little line here that goes to the posterior cerebral arteries wrap around. The point of this is not to study all these labels and so forth. It's only one thing. I just simply want to show that the entire brainstem is supplied with its blood from the vertebral basilar system. See all these little branches coming up. They're supplying blood to the medulla, to the pons, to the cerebellum, and to the midbrain as well. So the whole brainstem is getting its blood from the vertebral basilar system. Therefore, hemorrhages, which is a breaking of a vessel and bleeding into the surrounding tissue, and infarcts, which is a type of stroke in which there's a deprivation, a blockage, and then a deprivation of blood supply. Those two kinds of strokes, hemorrhages and infarcts, in the brainstem always are from a problem with one of these vessels that you're looking at right now. All right, so when that happens, here's the clinical implication. When you get a hemorrhage or an infarct in the territory of the vertebral-basilar arteries and their branches, what happens is you have an interruption in the ascending sensory and descending motor tracks. And you will get problems with the body, sensory problems with the body, and we'll look at the pattern later. And you'll also get motor problems with the body. And also, remember what was in here? We looked at it, I believe, in chapter 2. All those cranial nerve nuclei associated with cranial nerve motor function and cranial nerve sensory functions. And so little strokes even that are in the brainstem as a result of a problem with one of these vessels you're looking at right now will cause problem with the cranial nerves. Depending upon the pattern of the problem, the location of the stroke can be identified. So you don't need a CT scan necessarily to find out, first of all, that somebody had a brainstem stroke, not a cerebral stroke. And you just need to analyze the neurologic signs and symptoms, and it's readily apparent. Usually a brainstem stroke will show itself up as with a very clear pattern that you'll know by the time you finish this course. And it will also result in, as far as problems we're concerned with, dysarthria, dysphagia, or also impaired arousal and attention, because the reticular formation that is involved in sleep-wake cycles and arousal and attention is within the medulla and the pons and the midbrain as well. So what you won't get is you won't get an aphasia from a brainstem stroke, and you won't get a cognitive linguistic impairment or a minor hemispheric syndrome. You get a dysarthria, a dysphagia, that's GIA, or a problem with attention or arousal and or attention. All right. Now we're going to focus on the blood supply to the cerebral hemispheres and relate that information back to the functional zones of the cerebrum. Remember, we looked at the primary motor strip and the secondary motor strip, including Brodmann's area 44 and 45. We looked at the primary sensory strip for somatosensation, the auditory and the visual receiving areas. So we want to be able to associate problems with the blood circulation through these vessels with those areas. So that's where we're going. So from this point forward, we'll just be looking at the anterior cerebral artery, the middle cerebral artery, and the posterior cerebral artery. One of them, you might guess, or I kind of already told you, is particularly important to our scope of practice, and that would be the MCA. All right. So we're looking first at the anterior cerebral artery and its territory. And remember, I said that in order to really see its territory, you needed to do a mid-sagittal cut through the brain and separate the right and the left half. So we are looking, I don't know if you can orient yourself here. I'll give you a moment to do it, and then I'll orient you. We are looking at which side of the brain? Left. We're looking at a left brain. Here would be the frontal pole, occipital pole. Here's the anterior pole of the temporal lobe. Here's a corpus callosum. Here is a thalamus. It's actually the third ventricle. We're looking at the third ventricle with the massa intermedia, but we know that if you go deep to that, what do you have? Thalamus. And if you go down here in this area, hypothalamus. And then the entire brainstem is gone. So we're not even interested in that at this point. Remember, the brainstem got its supply from the vertebral-basilar system. So we're looking here. Now, what does the ACA supply? The medial portion of the frontal lobe, right back here to the precentral sulcus, just right there. And also the medial portion of the parietal lobe. All right, Um, Now, I want you to think about the zones, the functional zones. There is a primary motor and a secondary motor area, and it would be just in front of this precentral gyrus, so here. And you remember the motor homunculus. You remember the part of the body that was represented in this area? It is the lower extremities, the lower extremities. So if somebody had a blockage of the ACA, the problem would be not with the upper part of the body, but with the lower extremities. Which side? Well, it's going to be the opposite side, and we'll go into more detail on that. Later in this particular lecture, we'll see why it's the opposite side. And it's going to be a recurrent theme about crossing and why sometimes signs and symptoms are on the opposite side of the body from where the lesion is, and why sometimes they're on the same side. But anyway, you would have a loss of strength in the lower extremity on the opposite side of the body due to the disruption in the blood supply to the leg portion of the precentral gyrus and the motor strip. Then just behind is the sensory area. So you would have a corresponding loss of sensation, again in the lower part of the body, the lower extremity, I should say. So the area subserves the lower extremity only. Do people have strokes in that zone? They most certainly do, because if we talked about embolic strokes last time. If you get an embolism that dislodges itself from the atria of the heart and goes up the system and ends up going up toward the brain and ends up then blocking this vessel right here. Excuse me, I didn't mean to advance the slide. You would have a stroke in that, potentially in that entire zone that you're looking here, this whole thing, and they would lose sensation and strength in the lower extremity on the opposite side of the body. What they wouldn't have is they wouldn't have any speech, language, cognition, or swallowing impairment. So even though these people are in the hospitals, they definitely need physical therapy because they can't walk, and it's definitely an acute onset, and they definitely go to the ER, they will never see the SLP. I've never seen a person who has this, unless maybe it was coincidental, they had something else that we did see them for, and they also had a prior stroke or something involving the ACA. So certainly they do have it. But we're not going to be involved directly in the care of those people very often at all. All right, now I'm going to go here, and again, see we're looking at the territory of the posterior cerebral artery. We're getting to the important one, the MCA. So let's look at the posterior. It's the same image because we can only see the territory of the posterior cerebral artery if we do that mid-sagittal cut and separate right from the left. So again, we were looking at a left half of a brain from a medial viewpoint. And I've already identified the third ventricle and where the thalamus would be and the hypothalamus, so we're all good on everything. And here we see, and remember I said that PCA, posterior cerebral artery, I better just use the words here, how it was formed by a division in the basilar membrane artery at the junction of the pons and the midbrain, and how it wrapped itself around the midbrain and went to the posterior part of the cerebrum. And here it is. And then you can see it branches apart. It branches into all these little arteries, some of which are named. We're not going to learn them, but they are. And it supplies medial portions and ventral portions of the temporal lobe. And then more importantly, in terms of symptomatology, the primary and secondary visual cortex. Primary and secondary zones of the visual cortex. Now that would be BA 17, 18, and 19. So right around the calcarine fissure, remember the calcarine fissure, you have 17 and 18 wrapped around it, and that's supplied by the posterior cerebral artery. So this person would have a visual deficit, and we'll look in detail at why the visual deficit is exactly what it is. But let me just kind of get to the essentials of it. What they would lose is they would lose their visual field on the opposite side. They would be actually blind. not in the opposite eye, but in the opposite visual field. So if somebody had a blockage of this right posterior cerebral artery, this area would become infarcted, which means it becomes necrotic. It dies essentially, and it won't. Of course, it's not going to function. And that would, if they got a blockage, at a certain sudden time, they'd have a sudden loss of their visual field on the opposite side. So what they will then have is a left visual field loss or left visual field blindness. Again, it's not the opposite eye, it's the opposite visual field, which means when they look at a point of focus, wherever it is, wherever they look, everything to the left of the point of focus will be black. They won't see anything. And so that's the main sign. It is a sign. It's also a symptom that they would have. Now, what about all this area? Those areas down here are largely silent. So we're not really going to see anything that is easily testable or identifiable in terms of a sign or a symptom. All right, so now we go to the middle cerebral artery. And here we see the middle cerebral artery emerging through the Sylvian fissure. And we're going to go back into the Sylvian fissure and look at it again. But right now, I just simply want to show the branches of the MCA and where they go. And they do go to the primary motor strip and primary sensory strip. But the parts, not the lower extremity, the parts represented are the upper extremity, including the hands. Remember those great big hands of the motor homunculus, because you put so much brain power into the fine dexterity of the hands. And also that great big face, because you put so much brain power into the articulation of speech, probably the most complex motor behavior there is. And so the functional losses that would be apparent would be on the opposite side of the body, strength in the opposite upper part of the body, and loss of general or somatic sensation on the opposite side of the body. Now, let's see, that gets us down to here. Oh, now what about vision, audition? Remember the primary auditory receiving area? It's right here, Brodmann's area 41 and 42, also called Heschel's gyrus. Excuse me for jumping there, I didn't mean to do that. Heschel's gyrus. And that would be destroyed by a massive stroke in the area of an MCA. However, in terms of symptoms, there wouldn't be any auditory symptoms that are that are testable, very testable, certainly not clinically testable. You could do it experimentally, but I mean, with very sophisticated equipment. But in terms of how the individual is actually hearing functionally, they don't lose hearing in either of the ears, and they don't really lose hearing at all. The reason for that, we'll look when we get to the eighth cranial nerve pathway. The reason is that each of your two ears projects to both sides of the brain. It's a cross pathway. So it projects straight up and to the opposite side. So there's a protection. You don't lose your hearing as a result of a lesion in this area. Now, what you do lose is you lose something that's kind of like a higher level function, and that is language if the lesion is on the dominant side in Brodmann's area 22. And also don't forget 44, 45. I didn't put it here, but 44, 45 is right here. That's supplied by the MCA. So if this whole area were destroyed on the dominant side, you would have a very, very severe aphasia. But they'd be able to hear. They just couldn't understand what they hear. And then it does also supply the Brodmann's area 9, 10, and 11. And 39, 40 back here. Let me say something about 9, 10, and 11. If you had a stroke that was limited to 9, 10, and 11, and I said this before, and you're going to hear it again, there is no observable manifestation. There is no sign or symptom. And I think I mentioned examples of patients who've had good-sized strokes up here, up in front of Broca's area, and they didn't know they had them. It just got discovered coincidentally at some point when they needed to have a CT scan for some other reason. What's going on there? What's going on is that 9, 10, and 11, both sides do the same thing. So if you have a lesion on one side, the other side does the work, and there's no sign or symptom. Same thing for 39 and 40 to some extent, but there is more language processing. There's some specialization over here. So if you get a lesion that is behind Wernicke's area, and in 39, 40, there will be subtle language problems. And if you put it on the other side, you'll get a minor hemispheric syndrome. So when we get to cognition and language, we're going to review that again. But right now, you know, the main point of what we're doing here is just simply to show you the blood supply, and the blood supply is the MCA. Now what we're going to do in the next slide is we're going to get down into that Sylvian fissure a little bit and look at some very important areas of the brain that are supplied by the first branches off of the MCA. So this is a coronal view through the cerebrum showing, well, let's look at that down here with what we just studied, the internal carotid artery, a middle cerebral artery, an anterior cerebral artery. It's going out of our view, and that's not the point of what we're looking at here, but there it is. Here's our anterior communicating artery. Here's everything on the other side. So we have part of a circle of Willis here, not the whole thing, because what we really want to look at is we want to look at this MCA. And note that you've already seen this part. You've seen how it sort of emerges out of the Sylvian fissure and branches apart to supply essentially the whole lateral portion of the cerebrum, including all those things we just went through in the other slide. But what we didn't see is the first branches off the base of the MCA, middle cerebral artery, supplying the deep areas of the cerebrum. So these will look somewhat familiar. Here is basal ganglia. Here's a half of the thalamus. And here's a structure that I do not believe I have mentioned, at least I haven't talked about it, and that is known as the internal capsule. And we're going to look at that internal capsule in quite a bit of detail throughout more later parts of the course, especially when we get to the cranial nerves and so forth. What that internal capsule is carrying are all the motor neurons that originated like in Brodmann's area 4, and they have to get down to do something, and the way their pathway is to come together and go through the internal capsule and then down the midbrain, and then they go down to the motor neuron, which could be down at the spinal cord level, or it could be up at the cranial nerve level, go down to the motor neuron, which goes out to the muscle, and they form their synapse there. So that's how you move. You do most of your voluntary movements through a simple, well, I don't want to say it's simple, it's not, but a 2-neuron chain. A neuron that starts in the motor strip and goes down to either the cord or a motor nucleus in the brainstem, forms a synapse with a motor neuron that goes out to the muscle, 2 neurons. Well, here's that first order neuron from the motor strip coming down through the internal capsule. So that's one component of the internal capsule. The other component is all of the sensory pathways for somatosensation, for pain and temperature sensation, for hearing, and for vision, but not for smell. They all go through the internal capsule. What supplies the internal capsule with blood is these branches that are called lenticulostriate arteries. We're going to leave the lateral part off and just call them lenticulostriate arteries. And they are branches off the base of the middle cerebral artery that supply the basal ganglia, the thalamus, and the internal capsule. So sometimes you could get, and this is very frequent actually, people will get strokes in this area, right, from one of these branches, damaging the pathways through the internal capsule, and they'll get a hemiparesis on the opposite side. Maybe not the whole body, but a part of the body. And yet the CT scan shows that their motor and sensory homunculi are completely intact. So what happened? Why do they have the deficit on the opposite side in sensation and motor functioning? Because the pathways are interrupted from the motor strip and the sensory strip as those neurons travel through the internal capsule. The optic radiation, which is part of the visual pathway, goes through it too. So I already said that. I said all sensory pathways except for smell. All right, and clinical implications, we kind of covered that. So you can have a completely intact motor and sensory primary zones. You can have intact Brodmann's area 17, so you should have your visual fields, but you don't have your visual fields because the visual pathway was interrupted as it traveled through the internal capsule. Okay, so that's very important to know about these lenticulostriate arteries. People who have strokes in that area will show deep lesions in this area on a CT scan, but not out here. Okay, now we're going to switch directions and we're going to look at something which is going to be not immediately transparent, I think, is we got to look at this a few times. And that's why your book labels it the principles of contralateral and ipsilateral motor control. In other words, we're not going to look so much at the details right now, but I just want to say, or your book does, and I'm going to try to explain it, say some major ideas about how the motor system organizes itself centrally, that is within the brain and also the spinal cord. And so I've taken this this image, and it is not from the book, but I think it's kind of clear in a way. The details are not so clear, but I want to show two things. And one is I'll get back to the blood supply here, and then we're kind of done with blood supply at this point. But I did select this particular one because it shows the blood supply to the brainstem and how you get certain patterns of motor deficits. And so for right now, I just want to introduce the principles, not the specifics. But I think I need to kind of look at some specifics in order to get to the principles. So first of all, this is a little map of what's called the cortical spinal tract. And the cortical spinal tract is the tract that goes from the motor strip, the primary motor strip, Brodmann's area 4, down through the internal capsule. Here's our internal capsule. Here is a representation of basal ganglia. Here's a representation of the thalamus. And so it's coming down through there. Then it's coming down through the midbrain in a certain part of the midbrain. We'll look at that in more detail, but just notice it's coming down. It's coming down through the pons, and there's been no crossing. And it's getting down, and now this is in the medulla. This is a cross-section through the medulla, cross-section through the pons, cross-section through the midbrain. Now it gets down to the medulla, and way down at the ventral end, or I should say the caudal end, which is the tailmost end of the medulla, some of those neurons cross. Now, remember, these are some kind of long neurons. They go all the way from the cortex down here, at least to the base of the medulla, and notice they crossed, but they still haven't terminated on anything. Some of them will come all the way down the cord to the bottom of the cord, because they're going to then synapse on a lower motor neuron that goes out to a muscle of the lower extremity. So that could be that's about a 3-foot long neuron, and then it synapses on another 3-foot long neuron, and that gets you from the cortex to the toe of a 6-foot tall person. All right, so we've got these cortical spinal neurons going down all the way down the brain until they get to the very caudal end of the brain in the medulla, and some of them cross. Now, note that some of them cross and some of them do not. So let's go up here to what it says now. It says 80% of cortical spinal tract fibers or neurons decussate, meaning cross, at the level of the caudal medulla, forming the lateral cortical spinal tract. Now we'll look in more detail at this, but the lateral cortical spinal tract is out in the lateral funiculus of the spinal cord. And it's going to track, those neurons are just going to track down follow that pathway in that tract until they get to where their destination point is, and then they're going to leave the tract and they're going to go to the, here's an example, ventral horn. Remember, the ventral horn of the spinal gray is motor in function, and they're going to synapse on a neuron that goes out to a ventral root to a muscle. All right. The whole point of this slide, I'm sorry about the detail, but there doesn't seem to be any way of doing it without the detail. The whole point of it is that 80% of those cortical spinal neurons decussate at the caudal medulla, 20% continue on down, and they continue on down in the anterior cortical spinal tract. It's in the anterior funiculus of the cord. When they get to their destination point, they do the same thing. They leave the anterior cortical spinal tract, go to the ventral horn and synapse on a neuron that leads to a ventral root, goes out to a muscle. Okay, so most of them cross, some of them do not. Overall, you could say that if you're looking at cortical spinal neurons, 80% of them decussate. Now, the third point and the last one, and these are the principles I want you to have, not so much the details here. Of those 80%, they don't all go to different parts of the body in that 80-20 split. If you look just at axial regions of the body, now what's an axial region? It's your torso, your whole torso, not your arms and your legs, but your whole torso, your neck. Let's leave the head out for the moment because the head's a little more complex. Parts of your head act like they're axial in terms of this pattern, parts don't, but let's just take the body and forget the head at the moment. So we're focusing on the neck and the torso. For those muscles, if you just look at each lower motor neuron that comes out to a muscle from the cord, half of the input to that neuron is from the anterior cortical spinal tract, which means those neurons did not cross. And half is from the lateral cortical spinal tract, which means those neurons did. So I'm going to say it in a different way. Look at any one lower motor neuron going out to the muscle, a muscle of the torso, and half of its input comes from one motor strip, half comes from the other motor strip. Let me jump right to the clinical implication of that. If you were to get a stroke, for example, up in this area, and let's put it right into the internal capsule so that it disrupts all of the descending cortical spinal neurons at that point, because they're all trying to channel through this little area, you don't really get any measurable effect on the muscles of the torso. Why? Because both sides of your torso is getting input from both sides. So what happens really is that your muscles are 50% weaker, but that basically clinically is not measurable. You take a typical healthy person. What are you doing with your muscles? Well, of your axis, you're turning, you're maintaining upright posture, and essentially you can maintain your upright posture with 50% strength. What would show up clinically is if the strength were different on the two sides. And we'll see that when we get down to the upper and the lower extremities. But for the torso, it doesn't really show. If you happen to have strength measures before a stroke and after the stroke, you could see that there's a weakness. But functionally, it's not apparent. You take an old person who's barely getting around before they have a stroke, and then they have one of these strokes. And now they probably can't sit up, but they still wouldn't have an asymmetry. Hope that makes sense. So we would say that the weakness that occurs in these axial muscles from the result of an upper motor neuron lesion in the motor strip or the internal capsule on one side is really not detectable. Now let's switch to the upper extremities. That's what UE stands for. For the upper extremities, 85% of the input to each lower motor neuron is from the opposite side. In other words, that neuron crossed, it came down in the lateral cortical spinal tract till it got to its destination level, and then it forms its synapse. 15% were not crossed. And then further, if you look at that 85%, it's a higher percentage. I'm sorry, I didn't mean to skip. It's a higher percentage for what I'm calling the distal upper extremities. That would be further away from the body, i.e. your hand or your this, and 75% for the proximal. So we see greater control from the opposite cerebral hemisphere for the hand than you do for the upper arm, for example. The implications clinically for that is that after a stroke, you'd see the greatest weakness on the opposite side, upper extremity, greater in the hand than in the this area, for example. At each joint, if you go do the fingers are the worst. The wrist, they may have a little bit of movement. The elbow have a little more movement because we're looking at muscles that are closer to the body and getting more protection from the 25% of uncrossed upper motor neurons. Lower extremity, that's what LE, that's your leg. Same pattern, but not as extreme. And so you'll have to think about that a little bit, but it's the same pattern of mostly crossed neurons in the cortical, in the upper motor neuron pathway, but not as extreme as for the upper extremity. And so when you look at somebody who has had a big stroke here that interrupts everything, what they'll have is they'll have the greatest weakness of the hand, little less as you get up here, and also in their pattern of recovery. Now they may be totally unable to move their opposite arm at first, and then as you see recovery start to occur, they start to get a little movement in the shoulder joint. They still can't move the elbow. And then they get a little more strength at the elbow. And then finally, they may get the hand back, or maybe they won't because if the damage is too great. And whereas that same person who couldn't move the shoulder at all at first may be able to move their hip joint, around the hip joint a little bit, because they have a little bit of protection they have a little bit of protection here more than what they have for the upper extremity. So that's the general principle. I want you just to note the 2-neuron chain from the precentral gyrus. Didn't mean that. Okay, sorry, I'm jumping around. From the precentral gyrus and down to the lower motor neuron, wherever that is, whether it's in the brainstem or the body. We're mostly just talking about the body here at this point, and how there is this pattern of decussation, but some parts of the body receive different amounts of crossed versus uncrossed than do other parts in this pattern right here. All right, now that's a lot to absorb. I realize a lot packed into one slide, a lot of details here that can kind of throw you off, but I don't really want you to focus on the details at this point. Just simply the decussation at the lower medulla, and then the 2 continuations of that pathway, one that's crossed and one that's not. All right. I bet you'll have some questions on that. Okay, now. Oh, I said I'd mention something about the blood supply. This just reminds us that the brainstem is supplied by the vertebro-basilar system, and so those pathways before they get down to the decussation, that is above the decussation of the pyramids, can affect just one side versus the other in a stroke. And this is down at the level of the cord. And again, now we haven't got into the circulation for the cord at all, the blood circulation, but this does show us something very important, that you can have a stroke that involves just one side of the cord, but the other side is preserved. And so you can start to think about how actually easy it is for a neurologist to determine the level of a stroke or a tumor or an injury based upon this pattern of signs and symptoms. And we'll do the same thing as SLPs in terms of, we're going to focus more on, of course, on speaking, but you do want to see that your patient's SLP diagnosis and what you seem to be observing up here and assigning as a diagnosis gels with the rest of the body. So in that sense, we want to understand the whole thing. The other thing is, in order to link up your your oral motor exam or your oral exam with the dysarthria, etc., and make it make sense, you have to understand these pathways. And it's simplest if we understand them at the level of the spinal cord, because that's kind of it. I mean, what I just went through gives you the pattern for the whole body, just not for the head. Remember, I separated off the head. But if you don't get it here, you'll be really confused when we get to the head. So we want to understand the principles of contralateral and ipsilateral motor control with the body first. And then we'll get to the same principles and how they play out in a little more complex way when it comes to the cranial nerves. All right. Now, I think we kind of looked at this already, but this is a new slide. Injury involving the cortical spinal tract above the decussation of the pyramids causes, see if this doesn't make sense, contralateral hemiparesis, greater weakness of the upper extremity than the lower extremity. We went through all that. Greater weakness of the distal extremities than the proximal, and relative preservation of the trunk muscles. Okay, so we've done that, and it's the same illustration. So I think we've covered it. All right, let's go on to the next one. Okay, now we're going to look at the principles of bilateral control of the speech mechanism for one particular cranial nerve in a little bit of detail. And I guess at this point, what this illustrates is that the principles hold, but it's organized a little more complexly than what I just went through for the body as a whole. And we will look at this in detail. So this one actually is could be pulled from, I believe it's chapter 6, where we look at the motor control for the head and face area. But I'm showing it right now and going into it again, just to illustrate this crossing thing going on and the ipsilateral thing going on and how it plays out with the face. And so what we have here is, first of all, a face looking at us and a motor cortex. This is a cell body in Brodmann's area 4, motor cortex, in the face area. That'd be out on the lateral side, supplied by what artery? MCA. And it crosses. Now, a lot of the neurons cross, not in the decussation of the pyramids, but above. So the principle holds. It's just that this cortical spinal neuron didn't cross down at the level of the caudal medulla. It crossed up higher at the point where it needed to in order to get to the neurons, the motor neurons that go out to the face. Now, where is that? That is the facial nucleus in the pons. We did look at that in chapter 2. Remember, I said we're kind of just going through this real quickly, and it's not going to make much sense yet. Starting to make a little more sense here. What is that facial nucleus? The facial nucleus is a collection. It's a collection of lower motor neuron cell bodies that are going to send their axons out to muscles of the face, facial expression. And they have schematically divided it into 2 parts here. One with neurons going to the upper third of the face, and the other half of the nucleus with neurons going to the lower 2/3 of the face. And then they've shown the input to those 2 representative, highly schematic neurons. They've shown that the one neuron going to the lower 2/3 of the face is getting all of its input from the opposite facial motor cortex. Whereas the lower motor neuron going to a muscle in the upper third of the face is getting neuronal input from both facial areas of the cortex. Here's one, the crossed one, okay? And here's one that didn't cross. And note that the lesion is up here. So let's say that that is in the right internal capsule. Look at the signs. This is symmetrical up here, the top third of the face. And you can show it in other ways too. If you ask them to raise their eyebrows, they can do it symmetrically. If you ask them to close their eyes as hard as they can do it symmetrically. But look at the face at rest. Look at the face at rest. Normal configuration, but on this side, the opposite side from the lesion, there is drooping. And then if you ask them to retract the lips, they either don't retract at all on the left side or they retract less than on the right side. So you have that asymmetry of strength. Why? Because the upper motor neurons to the motor neurons, lower motor neurons that go to the lower 2/3 of the face are mostly crossed. Not 100%. This is a simplified illustration here. It's showing 100%, but it's more like your extremities. It's 80% or something like that. So you might have a little bit of preservations of function, but there is a definite droop. Contrast that with here. Now here again is our facial nucleus in the pons, and this time the lesion is in the facial nerve itself. It could be actually outside of the brainstem. You could have an injury, for example, that results in that nerve being cut, essentially cut. Or it could be a lesion inside the brainstem that disrupts that pathway distal to the facial nucleus. In other words, those neurons are trying to get to the edge of the brainstem and out to the muscle, but they're disrupted right there in the brainstem. And now look at the effects. There is drooping on the whole half of the face, and it is ipsilateral to the lesion. The lesion is of the lower motor neurons, either the nerve itself or inside the brainstem, but distal to the facial nucleus. And that's known as a Bell's palsy, and it's very easy to determine. Do we see patients with Bell's palsy? We do, primarily because, well, if you think about how their articulation would be involved, the bilabials, but essentially you can understand their speech, but there is some distortion of bilabials. The rest of their speech is perfectly fine because it's just the muscles of facial expression that are weak. And it's, in addition to the problem with the bilabials, you can see that they droop on that side of the face, the whole thing, and that very clearly is what's going on in this person with the Bell's palsy. This we're going to see a lot more often because we're going to see a lot of patients with strokes up in this area that affect the opposite side of the body. And now you know the pattern. Upper extremities more affected than lower extremities. Distal extremities more affected than proximal extremities. Torso not testably impaired at all. And now we get to the face here. Now, the first example of the face is the facial nucleus. And here you can see it's a little more complex, but the principles are the same. So let me see if I covered everything. Illustration of the cortical bulbar. I didn't mention that word. Cortical bulbar, the cortical bulbar tract is just like the cortical spinal, and it's actually with it. It's differentially labeled because it doesn't go down to the cortical. It doesn't go down to the spine. Cortical spinal gets its name from going from the cortex, motor cortex, down to the spine. This doesn't get to, this neuron isn't going to go down to the spine because it's not going to go that far. But it's in the same group of fibers. In fact, the whole thing is somatotopically organized. So if you know the somatotopic organization of the premotor strip with the motor homunculus. Now you go down to the internal capsule. It's somatotopically organized. The foot is on one side and the head's on the other, and everything in the middle. And then the whole thing is somatotopic, and so that those neurons that are only going down someplace into the brainstem are labeled cortical bulbar. By the way, you don't know this, I should say it. The bulbar part comes from the bulb of the brain. It's kind of an old-fashioned term, but that's how they are. That's how they're labeled. The cortical bulbar means they go from the cortex to the bulb, but not to the spine. Okay, and we talked about this two parts of the facial nucleus part. Note the bilateral input to the part innervating the upper half of the face, or upper third, really, I should say, upper third, and the contralateral input, or I should say primarily contralateral input to the neurons that go to the lower 2/3 of the face. We looked at the clinical features for lesions that are above the decussation and lesions below the decussation. Where is the decussation? I never mentioned that. We'll see this. We'll look at this in a lot of detail, so it's not really part of the principles, but just to try to make it make sense to you. This neuron decussates at the level of the nucleus it's going to. So this decussation takes place down in the pods. And we'll see the same pattern for every cranial nerve motor nucleus. The ones that are down in the medulla, the upper motor neurons came to them, that would be cortical bulbar, decussate down there in the medulla when they get to their destination, essentially. Okay. Now, nucleus ambiguous. Remember what the nucleus ambiguous innervates? It contains the cell bodies for the lower motor neurons that go to these muscles of the velum, muscles of the pharynx, and muscles of the intrinsic larynx. They are branchial efferent. Makes sense that they're efferent. Remember I said that you grew these from your gill arches and not from the somites that make all the other muscles of your body. And they have bilateral motor neuron input, which is a good thing, actually, because it means that if you get a unilateral stroke, you're pretty much protected to the velum, the pharynx, and the intrinsic larynx. They're going to be weaker, but not detectably because they're symmetrical. So for most people, they can have that hemiparesis, but then you look in their mouth and their velum is symmetrical, and you ask them to elevate it, and it doesn't elevate as well as normal. It looks like, it's hard to tell because it's symmetrical, but it does elevate. And of course, the pharynx you can't see, except if you do a modified barium swallow and you have them swallow barium, you see that barium is left over on the weak side. But with these folks, they usually don't have a weak side. They may have barium left over everywhere. Could be severe, it could be very mild. Why? Because their pharynx is weaker, but symmetrically weaker, so you don't see the asymmetry of the leftover material in the throat. And for the intrinsic larynx, they may have a kind of a hypophonia. They don't contract, they don't adduct as strongly, but it's symmetrical. Okay, so that's the nucleus ambiguous. So what am I doing here? I'm showing you that as we look at different parts of the brainstem and different cranial nerves, we're going to look at that principles of bilateral control and consider it again and see that for the brainstem, it's not quite as simple. It's not quite as simple as for the spinal cord and the muscles of the rest of the body, but you're going to get it because you already know about the face. Bilateral, symmetrically bilateral upper motor neuron control for the upper third, primarily crossed for the lower 2/3. Now we get to the nucleus ambiguous controlling these areas. It's 50-50, so the structures are fairly well protected against the effects of unilateral brain injury. Accessory nucleus, we're going to leave it off for now because it's not really part of the speech mechanism, and we're just trying to get the principles here. Hypoglossal nucleus. Now that's a nucleus that contains the lower motor neurons going to the tongue and through the hypoglossal nerve. You know that already, I think, from your anatomy and physiology. And those upper motor neurons, they would be cortical bulbar neurons, are primarily crossed. So what happens with the upper motor neuron lesion? Let's give it a big one, a big lesion again in the left, let's say the left internal capsule. You ask them to protrude their tongue, and they protrude the left side strongly because the left side got its innervation mostly from the intact right side. So the left side comes out well, but the right side doesn't, which means you get a deviation to the right. You get a deviation to the weaker side. We'll look in that. You're going to actually see how to examine it and be able to interpret. Or for right now, the opposite side of the tongue is weak, detectably weak. Why? Because the upper motor neurons primarily cross for that one. So now you know 7 differs between upper third and lower 2/3. You know about the nucleus ambiguus and the velum, the pharynx, and the intrinsic larynx, protected by the bilateral upper motor neuron innervation. And then you look at the hypoglossal, and we're almost there actually. Okay, this is I think it's the last slide. I just threw it in here actually just as a reminder to bring you back to what you learned in chapter 2 about the different nuclei of the brainstem. So you saw this in the picture. I showed you 2 pictures of sensory nuclei and motor nuclei that were located in the midbrain, the pons, and the medulla. I didn't show you this table, and I think it kind of helps to learn. Again, we have somatic motor, and this would be the 3 nuclei associated with extraocular movement: the ocular motor, the trochlear, the abducens. These are the cranial nerve members. We will see the effects of those in certain patients, but for the most part, those are protected. They have bilateral upper motor neuron input. So when you see your stroke patient who's got the droopy lower 2/3 and the tongue deviation, you ask them to look to the right, look to the left, they can do it. Their eye movements look normal. Whereas this same person their tongue will deviate, okay? Now, these are the branchial motors. So trigeminal motor, which we talked about very, very briefly. That's the part of the 5th cranial nerve that moves the chewing muscles. The bilateral, that has primarily bilateral motor input. We'll get to it again. I'm just throwing it in there, but it's not really the main point of this particular thing. Main point is to remind you again about the names of the nuclei, their classification as somatic motor, which we will study a lot, branchial motor, which we'll study a lot, visceral motor, not so much, because those are just going to control the glands, not too important for speech language cognition. General sensation, we'll study that in great detail, and that's all about trigeminal actually. And then special sensory and visceral sensory. Visceral sensory is for sensation in the area of the pharynx, and I didn't mention this nucleus solitarius. We'll look at that in detail, but I just put that in to give you a different view of something we looked at anatomically in chapter 2. Okay, now I think this is the last slide, and I'm just going to show what I just have gone through in a different way with a different view. Here, it's rather schematic, but it does show these red neurons, which are cortical spinal, for the most part, cortical spinal, originating in the motor strip. It says here, motor area of the cortex, and you can see they're spread out from the lower extremity area to the middle part of the body, to the upper extremity and face, and those great big hands. They're all coming down through the internal capsule. Here's a thalamus, down through the midbrain, down through the pons, down to the lower medulla, and here is where 80% of them cross into an anterior cortical spinal tract of uncrossed neurons and a lateral cortical spinal tract of crossed neurons. So that is referred to, I don't think I used the term before, decussation of the pyramids. Decussation means crossing, and the pyramids is just a name applied to these bands of tissue you can see on the outside of the medulla, that it's at the very, very caudal end of the medulla, and that's where the decussation takes place. Okay, and then we see coming down here, and we see at the level of the cord, various lower motor neurons leaving and going out, and it reminds us anterior nerve roots, those carry those lower motor neurons. Where are they going? They're going out to some muscle someplace in the body. Here is very, very a kind of a rough representation, a schematic and a representation of crossing of cortical bulbar neurons. And so this is within the brainstem, and you see different levels wherever there's a motor nucleus, either a branchial motor or a somatic motor nucleus that's going to subserve some cranial nerve. There's some crossing upper motor neurons there. All right, so what I've done, hopefully, is just orient you to this illustration and what the different parts are so that we can then go over here and imagine, speculate what the signs and symptoms would be for lesions that are at different levels of that system. Now, let's skip the first bullet point because I think it's the hardest, actually. Let's go down here to the second bullet point and imagine a lesion that is actually inside the spinal cord on the left at T6. That means halfway down the body. So we can just talk about upper half of the body and its function, lower half. That's why I put it at CT. T6, about halfway down. And remember, it's in the cord, not a ventral root. So it's in the cord at T6. Now, so I'm going to ask you now about just motor functions. Let's forget the sensation for the time being. What would be the primary signs and symptoms of that individual? I mean, since we don't have any sensory losses that we're talking about, we can talk in terms of visible signs. We're talking about strength or something like that, essentially strength. What will happen is that they will have a loss of movement of all the muscles on the left below the level of T6. So essentially that's the lower quadrant of the body on the left, every muscle. What happened to the protection they get from the decussations? They don't have any of that protection because the damage is done below the decussation. You only get the protection of a decussation if the damage is above the decussation. Then you have that partially preserved pathway that gives some protection and some function. But if the damage is below the decussation, there's no protection. So they will have a total paralysis of all the muscles in the left lower quadrant of the body. Hopefully that makes sense. Now, let's go to the third bulleted point. A spinal cord transection means completely cut at C2. In that case, well, there's not going to be any protection from decussations there either. They're going to lose all the strength for every muscle of the body below C2, which is almost every muscle. And in particular, as SLPs, we want to think about the breathing function. Will they have any preservation of breathing function? They will not, because they would only have preserved breathing function if the lesion or the transection were below C6, because remember, C3, 4, and 5 form the roots of the phrenic nerve, which innervates the diaphragm, and that's the one you really do most of your breathing with. So that would be the effect of a transection at C2. No protection from those decussations because, again, the damage is below the decussations. How about this fourth bulleted item, a lesion involving the entire territory of the MCA on the left? All right, well, let's say this person is facing us, and so this is their left, that's on your right. And now think, we're trying to link up our knowledge about what arteries carry blood to where, and then how that's going to manifest itself in terms of functional deficits. So let's think backwards from the MCA on the left. The MCA is supplying blood to the primary motor strip, sensory too, but we're not talking about sensory right now. We're just talking about the motor pathway, but only for that part of the pathway that carries information down to the upper half of the body. Remember, the lower half of the body gets its input from down here in the mid-sagittal fissure. So the cortical spinal neurons that are going to end up helping to move the lower half of the body originate in that mid-sagittal fissure. What artery supplies blood there? the anterior cerebral artery. Okay, so they're going to have a weakness, and it's going to be on the opposite side. It's going to be on the opposite side. Oh, hey, now look at this. As we travel down, as we look at those neurons coursing down through the internal capsule, we have to remember the internal capsule is supplied by blood, or it's with its blood from the middle cerebral artery. So you will cut all those off. So they will have a weakness of the opposite side, upper and lower. Down here is the decussation. So the lesion is above the decussation, meaning the signs and symptoms are going to be on the opposite side. Do they have some protection? Yes, they do, because they've got some neurons coming down here from the good side, from the right side of the brain, down, and they're not decussating. 20% of them don't decussate. And then when you think about the pattern of innervation to the different parts of the body, this individual will have the contralateral upper motor neuron weakness, most severe, lower extremity a little bit less, torso preserved, as far as its testability goes. Okay, so that is the entire territory of the MCA. And the fact that I said entire territory is important, because if it could be out here just on the lateral convexity and affect the upper extremity on the opposite side, but the entire territory does include the internal capsule. Okay, let's do the entire territory of the posterior cerebral artery on the right. The posterior cerebral artery, well, that's not going to affect this system at all. They will have a visual problem. We talked about that, but nothing here. So it's a kind of a trick question. How about a lesion in the entire territory of the ACA on the right? The ACA on the individual's right would be here, down here. So they will have a left lower extremity weakness. How about that pattern? Will they have greater weakness of the foot than of the around the hip area? Yes, because the lesion is above the decussation of the pyramids. Okay, that's a lot to digest. We're switching gears and just going to go to the neurodiagnostic tools for the study of speech language cognition. And I just picked out the ones that are, you're going to see reports in hospital charts. X-rays, of course, yes, but it doesn't show much on the brain. It shows the skull very well. If somebody has a skull fracture, it will show it. But it's not going to show the brain, because it does not resolve soft tissue well. For that, it's a computerized tomograph, a computerized tomography. And any area of the body could be given a tomographic reading, but this would be a CT of the head that we're concerned with, and that's going to be very, very common. It will show up a stroke. It won't show up a area of damage caused by a blockage right away, because the tissue remains and the density of the tissue is the same. But within a couple of days, it shows up very well. On the other hand, if somebody has a hemorrhage, it shows up right away, because blood has a different density to that computerized tomograph than does the surrounding tissue of the brain. So that's going to be a very, very common one. Well, you've seen them. Here they are. These are horizontal views of the brain at different levels, showing the skull on the outside, the heavy white line. You can see the gyri and the sulci. You can see the thalamus right here, shows up really well. What about here? Oh, this is above the thalamus, so it doesn't show a thalamus. It shows the ventricles if the section is through the ventricles. So here we see a part of the two lateral ventricles. Here we see a third ventricle right at the midline. It shows the subarachnoid space, which is this area of black right here. And you can see it looks quite large. I'm thinking that this brain has had some atrophy. And it shows the midline. Here's the midline. That midline looks like it's right in the middle, which is good. If somebody develops a large hemorrhage, for example, over here, it will push that midline over to the opposite side. We will look at that a number of times as we progress through the course.
Here's just an illustration, which I think you saw before, and I believe it's from chapter 1. It shows a schematic view of the CT machine. And in this case, it shows coronal views through the brain. And then here are more horizontal views through the brain. So there's nothing particularly new there, just a reminder. And then other imaging tools include the magnetic resonance imagery, which uses radio waves in a strong magnetic field. It's actually used in place of a CT scan when more resolution is needed. And you would maybe say, well, why don't they just always do an MRI and not the CT? Why bother? CT scan is much cheaper, and some hospitals do not even have an MRI scanner. They have to send the patient out. So that's the reason that a lot of things can be well diagnosed with a CT scan. For example, a hemorrhage can be diagnosed with a CT scan. An MRI is not necessary. So that's why we have two, and they would tend to start out with a CT scan. And if there's still a suspicion that something is there, but it can't be seen on a CT scan, they'll do an MRI. A positron emission tomography measures the metabolism of radioactive glucose processing, and it will show up the areas of the brain that are active. I don't want to say that it's never used clinically, because it is, but it's not very common, particularly in acute care. You know, like people who go to the hospital for strokes or traumatic brain injuries, very rarely would they have a PET. And most hospitals do not have a PET scanner. And then same for single photon emission tomography, a SPECT, produces images that are similar to a PET, but lower in quality. UCI Medical Center would have that, and they'd have that capability. They might do it, for example, on somebody with Alzheimer's disease to help them to try to diagnose the disease. EEG, electroencephalography, that's very, very common. And it measures the electrical activity produced by the brain. It's not invasive. They just put the electrodes on the outside and measure it. And it can certainly be used to diagnose something like a seizure disorder. When somebody has a seizure, they'll for sure do an EEG. They don't necessarily do an EEG on stroke patients typically, but it can be, and you'll certainly see patients who have EEGs that's easy and inexpensive to do in a hospital. And then evoked potential. I think you know about evoked potential from studying audiology, if you have done that yet. Evoked potential is a technique for measuring electrical activity in a short period of time following a particular stimulus that keeps going. So for example, for auditory, what they put into the ear is click, 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 click. And each time there's a click, they measure the electrical activity of the brain, and what begins, you see all of these just crazy waves at first, but as you summate the activity over a number of clicks and the brain is responding to each one the same, you then can begin to see a pattern that shows the integrity of the sensory pathway within the brain. And that's the point of it. So for example, if a child, they suspect a hearing loss in a child who can't respond to normal audiometry, they can do an evoked potential and see if the potential is showing that the information is getting up to the Heschel's gyrus. It can show all the way stations on the way up to Heschel's gyrus and allow them to test hearing in a different way without the necessity of having the person tell you if they can hear it or not hear it. All right, so that is the end of that very long chapter. It will not feel solid to you yet, and you just don't have enough of the picture, but hopefully you know everything you need to know about cerebrospinal fluid circulation and blood circulation, and you have some rudimentary starting information on the pathways that are crossed and uncrossed for the motor system. And then we're going to tick through the individual cranial nerves, and we will embellish that and provide details, but it should go back and gel with this. All right, let's just take a look at these 5 simple questions, and I'll go through them with you. A mixed nerve is descriptive of all cranial nerves. No, it's not, because there are some, like the abducens nerve to the eye moving muscle.
It's got only one thing in it, somatic efferent neurons. That's it. It's not mixed. Is it descriptive of all spinal nerves? Yes, it is, because all spinal nerves have both sensory and motor. Is it descriptive of the peripheral ganglia? Oh, that's kind of a trick question. I'm not sure if you have all the vocabulary you need for this. A ganglion, ON would be singular, is a collection of cell bodies outside the central nervous system. Oh, you do know what? You know the dorsal root ganglion. And the dorsal root ganglion is a collection of cell bodies in the sensory pathway, and that's the one. So is it mixed? No, it's got only sensory. Tricky question, but you do have the tools to answer it. A mixed nerve is a nerve that carries both sensory and motor fibers. Yeah, well, that's true too. So B and D. The first order sensory fibers, axons of the spinal, by fibers I mean axons, of the spinal nerves are located in the posterior root ganglion, not the ganglion, because the ganglion is the collection of cell bodies, are located in the posterior root of the spinal nerves. Yes, the sensory fibers go that way. Are located in the anterior horn? No, that's about motor. Are efferent? No, they're not efferent because they're afferent. They're carrying information back to the central nervous system. A lesion within the spinal cord at a particular level of the cord. Okay, now I went back and I changed this to put within the cord. It's actually in the cord, not out in one of the spinal nerves or the roots or anything. It's in the cord, but it's at a particular level, from top to bottom in a certain place. And I gave an example earlier of T6, a lesion in the cord at T6. So what's the effect of that? It can impair functions at the level of the lesion and below. Yes. It can impair functions at the level of the lesion only. No. That would be if the lesion were in this root or the spinal nerve. It can impair functions at the level of the lesion and above. Oh no, that wouldn't work. It can impair movement, but not sensation. No, it can impair both. Mostly we've talked about movement, but your sensory pathways have to go up the cord too. Number 4, the meningeal layer that is nearest to the brain is the pia. Okay, that was an easy one. A lesion involving a cortical spinal neuron below the pyramidal decussation would, in theory, impair some motor function on the side of the body contralateral to the lesion. Not contralateral, ipsilateral. The key here is that the lesion is below the decussation, below the crossing of the cortical spinal neuron. So the effects will be on the side of the lesion. All right, that is all, and I'm going to stop sharing the screen and end the session, and we will answer questions later next time in our class. Bye-bye.